My pico question for my lightning strike this semester is, in collegiate football, will plate fixation compared to intramedullary fixation in the treatment of displaced midshaft clavicular fractures lead to quicker return to play rates and fewer complications? So the clavicle is a bony structure that connects the axial skeleton to the appendicular skeleton at the upper extremity. The clavicle is also responsible for stability and movement of the upper extremity, as well as providing protection to the neurovascular structures that lie underneath of it, such as the brachial plexus and the subclavian arteries. When it comes to clavicular fractures, they can be classified using the Allman classification system. So with this system, you have group 1, group 2, and group 3 fractures. Group 1 fractures are known to be the midshaft or the middle thirds of the clavicle. Group 2 fractures are known to be the lateral or the distal 1/3 of the clavicle, and group 3 fractures are the medial or proximal 1/3 aspect of the clavicle. For this presentation, I'll be focusing primarily on group 1 fractures, more specifically displaced midshaft clavicular fractures. So these are the most common types of fractures that there are. They account for 69 to 82% of all clavicle fractures in the general population. Over a 5-year study, displaced midshaft clavicular fractures in football accounted for 12% of all sports-related injuries. Over that same 5-year study, displaced midshaft clavicular fractures accounted for 8% of all injuries in national collegiate football. So 30% of those fractures occurred during practices, whereas 70% of them occurred during games. So the most common mechanism for a displaced midshaft clavicular fracture is going to be falling onto the shoulder, onto the playing surface, applying an axial load onto the clavicle itself. So one common surgical method used for a displaced midshaft clavicular fracture is plate fixation. The method can be done anteriorly or superiorly. The only difference in the two is that with the anterior method, it's not going to be as prominent as compared to the superior method. So typically it's a 3.5 millimeter dynamic plate that's fixed onto the clavicle, and it is drilled down using a minimum of 3 screws on each fragment of the clavicle. Typically it's going to be more than 3, but it will always be a minimum of 3, solely for the fact to get one onto the medial, the midshaft, and the lateral aspect of the clavicle. When there's extensive stripping or gaps on the cortex of the clavicle opposite of the plate, there might be suggestions to use a portion of the iliac crest as a bone graft in the clavicle itself to help the fracture healing process. So in one study of 30 athletes that replaced plate fixation for displaced midshaft clavicular fracture, all of them returned to play following the surgery. 7 of them returned to play in less than 6 weeks, and 20 of them returned to play in less than 12 weeks. So there were 3 complications reported, but all of which none were reported to be major complications, such as refractures, plate fractures, or deep wound infections. The surgical intervention that I'll be comparing with plate fixation is going to be intramedullary fixation. Someone may choose this technique over plate fixation due to the lower chance of infection, a smaller incision, and the removal of the hardware itself. So with this method, it uses 1 screw that is drilled into the medial aspect of the clavicle and 1 screw that is drilled into the lateral aspect of the clavicle. And then a pin is placed between the 2 screws, going through the site of the fracture, pulling that displaced clavicle back together. So once there is radiographic evidence of fracture healing, then that pin is then removed for the fracture to heal naturally on its own. In a study of 58 athletes that received intramedullary fixation after displaced midshaft clavicular fracture, there were 15 reported complications, 5 of which were considered major complications, so it could have been anywhere from a refracture or movement of the pin, so having to go back in to replace the pin, and then 10 of those complications were reported to be minor, that didn't require any secondary surgery to go back in for it. Regardless of the complications, though, all 58 of those athletes did return to play on an average time of 67 days. So in this picture, this is just a quick little reference. So this is Tony Romo. I'm sure that some of you have heard about him. He did have 2 different, well, he refractured it twice, but he had a clavicular fracture, and as you can see in this picture, that mechanism is him getting tackled and falling onto the playing surface, giving that axial load onto the clavicle. So, in conclusion, After researching these two surgical techniques, it has been found that in collegiate football players, plate fixation would be most beneficial. One of the significant differences in the two techniques is that with plate fixation, that plate remains on the clavicle, whereas for the intermedullary fixation, that pin is taken out when the fracture begins to heal. So in football, it might be a good idea to have that rigid stabilization as protection against future clavicle fractures, whereas with the intermedullary, when you remove that pin, that fracture is healing on its own, and if something were to happen, that athlete would be more likely to have a refracture, whereas that plate would provide that stabilization. That's also especially because football is a contact sport, you don't want to take any chances of going back down and refracturing that clavicle. So there were also fewer reported complications and a quicker recovery time with the plate fixation technique.